session 4, and now we finished up the IV, so let's finish up chest, and we were on blood gases. Now, do you need to review the norms again, or you got to cut it in your head? Get in your notes to blood gases. No, I think you did them yourself, because we worked some. You made notes yourself. And, tell me when you got them. Okay, let's review the norms. You don't need it, but just keep in mind, it's just good to know, O2 should be 80 to 100. We don't use that in this, but just remember 80 to 100. But what we do use is the pH, and when we're checking, we want 7.4 only, 7.4. Anything below 7.4 is acidotic. Anything above 7.4 is basic. And then, that's the first one we need to know, the pH. And, this is arterial blood, ABGs. The second thing we need to know is acid, O2. The CO2, PCO2, which is 35 to 45, and then the HCO3, or bicarb, 22 to 26. So with those three, pH, bicarb, and carbon dioxide, we need to decide what's going on with this patient. So, we were doing some examples to see if they're compensating or not compensating. And if you remember on compensated, and there you could turn to your agenda to that page in the agenda that we did, it was the chart thing, and I liked some of it and I didn't like all of it. You remember it? Mm-hmm. Page 8. Yeah. So keep your finger on 8, page 8. I like, I go for all of it except the compensating. So your big decision with this patient is, are they acidotic acidotic or alkalotic? That's number 1. Number 2, are they in respiratory or metabolic situation? And number 3, or how are they compensating? Fully, partial, or none? So let's work 1 or 2 again, and see how you do. All right, let's take the pH is 7 point. Is that a 6.5?
Yeah, 6.6.
7.66. Okay. PCO2 is 27, and HCO3 is 10. 10.
19.
19. All right. So we say, we're going to say, is this patient acidotic or alkalotic? Alkalotic. Because 7.4, it's 7.66, they're up past. All right, number B, Rome, remember? RO. They're in respiratory if pH and CO2 are opposites as far as up and down. So pH is high, high. But the PCO2 in this one is down. See, 20, what was it, 27?
27.
And what's normal? 35 to 45. So it's down. Do I have my opposites? Yes. So this patient is in respiratory alkalosis. Now remember, now I let you do a pH of a range, 7.35 to 7.45. I didn't let you use a range when we were deciding if they're acidotic or alkalotic. But for compensating, I want you to look at it. So, are we at a 7.66 fully compensating?
Actually,
No, because it's 7.35 to 7.45 and it's 7.66. So they're not fully compensating. Then you look and see, now you know 7.66 is out of range of 7.35 to 7.45. Is the PCO2 out of range? Yes. So it's out. Is the 19 bicarb out? Yes. All three of them are out. When all three of them out, it means they're all trying to help each other. They got out of their comfort zone and are helping each other, so it's partially compensating. So this patient is partially compensating. They would not be compensating, no compensation whatsoever, if bicarb or CO2 stayed in their range. It means they don't have the full cooperation, so there's no hope. They are non-compensating. All right, so this patient's in respiratory alkalosis, partially compensating. All right, let's do another one.
are you going to cover what you do?
Do what?
Are you going to tell us what you do for them?
When I get through this. Okay, so let's do another one. 7.22 is the pH. PCO2 30, HCO3 14. Now don't get out of, stay on your pattern. Number one, are they acidotic or alkalotic? And they're acidotic. Now, are it Rome, RO, are they respiratory opposite? pH is down and PCO2 is down, isn't it? So that's not opposite. You could go to the rest of Rome. They're metabolic if they're doing the equal thing, which they're both down. So this patient is in metabolic acidosis. Now, let's see if they're compensating. 7.22, no, they're fully not compensating, or it should be 7.35 to 7.45. Are all three out of range?
Yes.
So this patient is partially compensating. Now, let's do this one. 7.01 pH. PCO2 37 and HCO3 9. This patient is in acidosis, correct? At a 7.01. They're acidotic. Now, number two, are they in respiratory? Respiratory, opposite, RO. Well, the pH is down. And, no, they're staying in range. So we can't say it's opposite. If it's not opposite, it is metabolic. It has to be opposite directions. And see, it's staying in range. 37 is in range.
Right.
So it didn't go opposite with pH. So this patient's in metabolic acidosis. And we already know 7.01 is not fully, right?
Right.
So it was out of range, but PCO2 stayed in range at 37. 35 to 45, is it?
Yeah.
So it stayed in range, and I already know if one of those two stay in range, they're not compensating. It's just they're staying in their home and not helping anybody else. So there's no compensation.
It is. It is.
Have you got it, kinda?
I got it.
One more and then we'll talk about what to do about it. 7.36, PCO2 30, HCO3 15. This patient is acidotic because I want 7.4. You're probably looking at that range. You don't look at the range till compensation. 7.36 is acidotic. In Rome, RO, respiratory, are they doing the same thing?
Low, yes.
Well, 7.36 was down, wasn't it? PCO2 was down, and that's not opposites. They both went down. It means they're metabolic. So metabolic acidosis. 7.36, are they compensating?
No.
Fully.
They are?
7.35 to 7.45, and it's 7.36.
So they are in range on that one.
See,
The
7.36 for
7.36.
full compensation, 7.35 to 7.45, and they're 7.36.
So they are, okay.
Now, Heather wants to know what we're going to do about it, and we're going to tell her what we're going to do about it. But also, we need to know what makes you get that way. So we need to go over that part too, as well. We'll just take, let's take respiratory acidosis. Respiratory acidosis, and the reason, that's probably the most prevalent, COPD. Anything that keeps the exchange from happening in the lungs, CO2 and O2, and the things that can cause that is chronic obstructive pulmonary disease. We don't do it well. We don't exchange well. Severe pneumonia, your whole inside of your lungs is loaded with stuff, and so there's not much perfusion. So severe pneumonia will do it. Cardiac arrest will do it. ARDS, acute respiratory distress syndrome. Acute respiratory distress syndrome. And let me stop to talk about that a minute. I'm trying to decide where to start. ARDS is just what it's, perfusion isn't happening. And ARDS is acute respiratory distress syndrome, but what it happens is oxygen especially isn't getting exchanged for CO2 for various reasons with ARDS, but the biggest reason is blood may not be getting there. If you've had in the battlefield or Vietnam, they brought out the lungs of the boys died of ARDS more than anything else, and it was because if they had a bad accident, a leg or something, the blood was, if it was decreased by the time it got to the lungs, and so in that decreased amount, it's not perfusing well, and so if we don't have that good exchange, then the lining, the alveoli of the lungs start getting some irritation, some inflammation, And in doing inflamed, then blood that does go up there may cling to it. And they called it the Vietnam lung because they could put it up on the x-ray board and it looked like salt sprinkled all over the lungs. And what it was little clots because the blood was just getting caught. It was, I always think of it as just kind of slowly getting through as far as oxygenated blood. And so it was of irritation to villi to not have that full oxygen supply, so they swelled and they got edematous. And with that, little clotting took place.
What was the name of the x-ray? What did you call it?
Huh?
A Vietnam x-ray? No.
Oh, they called it the Vietnam lung, but it's ARDS. If you have a bad case of ARDS, it's not good, even in America. That was on the battlefields, and it wasn't good. And it's hard for physicians to pull patients out of ARDS. It can be done, and you've got a good physician if they can, or whatever. The good Lord and a good physician, I guess. But because what would be wonderful if you could have a hose that's loaded with oxygen and blood and just clear out the lungs. That's what it needs. We don't have any mechanism to do that. You want to invent it? It will be famous. So we just have to deal with that low blood supply. The other thing that causes ARDS is the gram-negative rod, septic. And you can imagine, because if our blood is loaded with germs, there's not going to be a good perfusion back and forth. And so we may not be bleeding out, but the result's the same. The irritated villi, the inflamed villi, and that's ARDS. It is tough. If you ever nursed an ARDS patient, it is so tough because you usually have to restrain them because they want to pull their E-tube, and they're restless and combative.
So they're not coherent?
No, because the oxygen's so bad. And I know sometimes I've gotten irritated with doctors because they think nurses, which some do, just want to give a sedative, especially in the unit, let them sleep. And you can't with an ARDS that you're trying to wean. And I've heard some ugly, snarky comments from physicians the next morning when, well, the nurse didn't get to rest because she couldn't give narcotics to the ARDS patient. And because they don't want to give them anything to calm them down or they'll keep sleeping. And they need to be breathing on their own. They need off of the ventilator. And so it's a tough medical situation, ARDS as well. But I meant to talk to y'all about it, and so that's one big reason that patients go into respiratory acidosis. Even drug overdose, and you can believe it, if you're not breathing very strong and deep because of a drug overdose, then that exchange is not good, and you'll easily slip into this. Pulmonary edema. So those are some of the ways you get respiratory acidosis, but you get rid of it, we hope, with a ventilator, a respirator, pushing air in. Remember PEEP we talked about that keeps the villi open so it doesn't stick together and close. PEEP and the ventilator opening up the villi to get some exchange. So that was respiratory acidosis. Let's go to respiratory alkalosis. And respiratory alkalosis is too shallow breathing. And we do that. You think you breathe fast when you're scared or anxious, but you don't breathe very deep when you're anxious and scared and in pain. And so your breathing is shallow and not deep enough. And pain, fever will all cause respiratory alkalosis. And so any of those that make you scared or pain or fever and you're not breathing deep, you'll go into alkalosis. And the way you treat it is calm people down and instruct them to take slow, deep breaths. And that's your business of slow down, take a deep breath, because they're easing into respiratory alkalosis. Now, let's do metabolic acidosis. Metabolic acidosis, and we get that by diarrhea, diabetes, if you go into a reaction, you know, that's usually when people have a diabetic problem. A lot of times it is metabolic acidosis. And that's the biggest reasons people get starvation can cause metabolic acidosis. And what you do about it, of course, if you're diabetic, you get the diabetes straightened out. But anything else they might use by carb.
So with the diabetic, is it because they have too much insulin or not enough? Or could it be either?
Okay, so if you're in metabolic acidosis, you've got too much, don't you, sugar? Now, then the last one's metabolic. Which one am I lacking? Alkalosis. Is that right? Wait a minute. Yeah.
Well, you did respiratory alkalosis.
We're doing,
And then you did metabolic.
we're ready for metabolic alkalosis, aren't
Okay, I got you. Metabolic.
So our bulimic patients,
Alkalosis.
they
Do what?
would be more, a bulimic would be likely to have a
Uh-huh,
metabolic
uh-huh,
acidosis. Okay.
I think an eating disorder would ease into that. Now, metabolic alkalosis is electrolyte depletion. Can you say, well, diarrhea, the other one we had was diarrhea. I know, and you may get a mix of all, of a little of both, off and on. But for the most part, metabolic alkalosis is electrolyte depletion. And that can be NG tube, diarrhea, or diuretics is a big thing. And treatment is some kind, is electrolytes, sodium chloride or potassium chloride. I think. Any other questions on blood gases?
Any kidney patients wind up in one of these?
Do what?
Kidney patients, the dialysis patients? You just did dialysis.
I used to.
You moved.
I mean, it's usually fluid buildup, and then if they
What?
lose it,
Are they usually stuck in one of these states?
I mean, I did an outpatient
What?
clinic. She's
What's the
asking about
question?
Kidney
like a
patients.
patient on
They're usually
dialysis,
kind of always stuck in.
and I did outpatient. So I mean,
They really
we
take
basically
into
just were taking
account
the
all of
fluid off
that.
and cleaning.
Like they bolus you with electrolytes, and they've got it so fine-tuned. Anybody been a dialysis?
Well,
nurse?
yes, ma'am, I was. I mean, mainly the patients came in and if they didn't really follow their diet well, then they, excuse me, my voice is terrible. Basically what you were, well, obviously you were filtering their blood, but a lot of times they would have fluid build up. So a lot of what you would do is get the fluid off. So you're, like you said, you're basically just trying to get everything back to normal electrolytes.
Yeah, they've got to get the fluid off, but they've got to keep the electrolytes balanced
Right,
too.
and there was always a dietitian that came around that talked to them about, so they could come in good shape versus you could tell the people that had followed their diet, and so their diet had a whole lot to do
Yeah,
with it.
sure. All
A lot
right.
of the dialysis patients have problems with their phosphorus. Being kind of on the upside.
Yeah, and they always had, I mean, every patient had a dietitian, like every time they were there, that came around and discussed all of them.
And Delinda bringing up
All of
that, I think it's important to take into consideration, you and I, if we have no kidney issues, can rid ourselves of phosphorus. But if our kidneys are not optimum, it doesn't, and get rid of it, and so it builds up. And so there's just a best little plan they got, and that is to take aluminum hydroxide, which is like Malox. But a patient really, and they're pretty good at enforcing, that a patient who needs aluminum hydroxide, if they take it, it's like Malox, the phosphorus binds and goes out the feces. And so you don't have your buildup. The worst problem is they'll go to the pharmacy and look for aluminum hydroxide or the generic name, which it is, or they'll think Malox is the same thing, but it isn't. Malox is a little different. They're both white chalky and people take them for whatever. But a dialysis patient or a kidney type patient needs aluminum hydroxide orally to bind with the phosphorus to go out the feces, since the kidneys can't do it. Now, I think, I think we're kind of through with lungs, and we're through IVs, so let's look at medicines for just a little while. You know, I don't like to do it too long. Go to your agenda, and I have to count on you all. I think I know where we ended. Do y'all know where we ended? GI drugs, go to your agenda. Parkinson's.
Diabetics.
Where do y'all think we were?
Diabetic supplies.
Which one?
Page 17. Page 17. We got that.
17, are y'all sure?
Yeah.
17 is,
17.
Y'all really think we're that pitiful?
I've got notes all the way.
Huh?
We ended in 17?
you said
Oh,
start,
yeah,
you said
okay.
start here, yeah.
Well, good, all right. So, let's look at ear, mouth, and throat. And the only one that I have marked that's used a lot around us is cliamycin, or clinicin. It is a powerful antibiotic. I think it's expensive too, isn't it? Has anybody got a history with that one? On page 18 of the agenda, go all the way down to xylocaine, viscous, and just realize that it is just that, just a numbing situation. They, I think, I'm not sure if we've mentioned, you know, there's several drugs that really hurt the veins. Potassium's one of them. If somebody's getting potassium, it really hurts. And So if the physician orders, pharmacy can put some lidocaine in it. And it's really frowned upon that physicians do that because it still scars the vein. It just doesn't hurt to scar it. And it may inflame, but you don't hurt because it's numbed it. But I promise that vein will never be used again. So what do? You cut it down. Potassium runs at 10 milliequivalents an hour, or 100 milliliters an hour, and you cut it down to run 25 an hour. Just make it less caustic. So I just wanted to say that.
Does that cut the damage?
If you'll do it slow with a lot of fluid with it.
So diluting it.
Mhm.
Okay.
Then the other one is Bactroban, and I think we talked about Bactroban, didn't we? How over the counter it's diluted, but if your prescription, be very gentle and careful with it because we don't want you immune. Nystatin cream is just for fungus or in it, and you know, we have the Nystatin mouthwashes, swish and swallow or swish and spit, and it's either one. I like the swallow better because it goes through this down to the esophagus. Make sure they don't, drink afterwards. Let it work in there. I make students clean their mouths real good, the patients. Get them a good clean mouth before you put it in. They don't have to work through crud. So there's the cream. Silver Solvadine. I'm just always shocked that Solvadine is still, it's still such a good drug and still being used. Silvadine. They still put, not very often, but I've seen it still occasionally put in children's eyes. We used to always put it in children's eyes. And then in the little print, I don't think there's Cipro there, and nothing particular. Go on down to the eye drugs. And the only one I've really marked, of course there's ciprofloxacin and those, but Temoptic, and it's for glaucoma, is it? I want to say that. And then there's tobramycin again, just an antibiotic. Now, heart and circulatory drugs, you need to look at those. And amiodarone is antiarrhythmic. Amiodarone's awfully hard on the kidneys. But I know people have had it for life and they're old, so they had good kidneys, I guess. Norvasc, or amlodipine, is for blood pressure. And then Lotril, blood pressure. These are antinormin or atenolol, blood pressure. Every one I've marked so far, and then Lotensin, blood pressure. Now Bumex, and see, mixed in here, if you get somebody's blood pressure down, that, if you can get their fluid a lot of times down, it helps their blood pressure. And Bumex is going to do some of that. Catapril, blood pressure.
What's Phoenix? Is it diuretic?
Do what?
Is it a diuretic?
Mhm.
It's a blood pressure diuretic.
It's really for blood pressure, but it's really taking fluid off to do that. Bumex. Catapril, and I'm going to go over these some more, but that's for, it's one of the prils. And the Prils,
Lisinopril is like a real popular one, isn't it?
they're what?
Lisinopril, isn't
Uh-huh.
it? That's a real
Yeah,
popular
Lisinopril. I think,
one.
I think I'll talk to you in a minute on it. But, the Prils dilate arteries, which decreases the blood pressure.
The beta blocker.
It's it is an ACE inhibitor. The Prils, that what Pril did we just do? Yeah, anything that ends in the Pril, Pril, is an ACE inhibitor, and they do result in blood pressure by dilating the arteries. And then, and we'll get, let me look some over there. That's Catapril. Then Coreg, real popular for blood pressure. Catapres or clonidine. And digoxin increases the contractility of the heart, makes it contract better. Now, the next page, Vasotec, blood pressure. And there you are with Lasix, which is going to do that, getting rid of the fluid, which cuts the blood pressure down. Lozol, I'm not sure if Lozol, I know it will help the blood pressure. I don't know how, though. Now comes Lisinopril, and I can't remember. We did talk about, didn't we, how that it's so often given with diabetics to protect the nephrons. And it's that pressure, it cuts down pressure. And I told you, if you think of diabetes as shreds, sugar being glass, and it filters through the kidneys, it just tears up the kidneys. And that's why diabetics just have terrible renal problems a lot of times, because that diabetic sugar has just ripped apart, if you'll think of it as glass, their kidneys. And somebody serendipitously discovered if we'll give them lisinopril or an ACE inhibitor, any ACE inhibitor will do it. Lisinopril is so cheap. But then, as I told you the other week, be real careful if 5 years after being on it, somebody becomes allergic to it. Numbness usually in the face. Also, Cozar. Do you see it at the top of your page? It says Cozar plus diabetes mellitus. Cozar will do that as well, protect a diabetic's kidneys. And there's Cozar's next. And then Melvicor, and that's a statin. And I just have a hard time with statins, but I really do. And I don't, please don't take my word on it, because I'm no good. You know, they reduce cholesterol in your bloodstream, and so often cholesterol coats the veins, and then pieces drop off, or they occlude the vessel, or they chip off, and then why am I against it? Because I think it's a fad, and I don't know why. I just feel it because everybody's on it. Everybody's on them. And I've told the doctors that, and you know, I'll argue with them. But I don't know why. It's a feeling, I just know that people lived for years and years, rural people, and they were fat. Now they were fat, and they lived to be 90. And that is part of what bothers me. And so we give, okay, and then this is another. I've got several reasons I don't know. So I'm not telling you not to take a statin. My husband is just a type 2 diabetic, and I didn't want him to take statins, and he has a coronary. So how bad did I feel? Well, he's real sweet. He told me I don't feel bad. I don't feel real guilty, but he takes statin now. I will say that. And he didn't ride me, nor the physician, because the physician knew I didn't want him to take it. And but he's fleshy. He's carrying some weight, and so. But here's my worst story. Not worse, but one of my big things is cholesterol's a good thing. And it's so, well, some of these people are saying we've gotten way off by people cutting down their fat, because we need it. And that's the other part. And they say, well, statins do the bad. Well, come on. So somebody told me, it was a dietitian, she's really against them. That was part of why I'm against them. She says, if you're going to consider, take diabetics, and they're ones that, if you're diabetic, they want you on statins. And her point, here's their point. Glass is in your blood. It's scraping the veins. They stay inflamed. Her point is cholesterol lubricates them. And that's why she's against cutting down the statins when you're a diabetic. And she tells the story of that awful Dick Cheney, the vice president, who had a heart attack. And the papers, I don't know whether you remember, I do, just went on and on about his cholesterol. Way sky high, sky high. I don't know if he's diabetic. There are other ways that your body gets inflamed veins. Why? Sometimes we don't even know. Maybe it was an antibody we picked up that scraped it and started inflammation and needs some time. Maybe when you had your blood drawn, something made you inflamed. Who knows? Diabetes isn't the only reason we have inflamed veins. Anyway, Dick Cheney has a heart attack. The media just went on and on about his high cholesterol. And as this dietitian said, so they get it down, and everybody's so proud of him, and it's all publicized how low it went. He has 2 more. Well, he had, according to her, he had 2 because they took away the one thing that was protecting him when they got it down so low. He was high cholesterol because he had some inflammation in his vascular system, and instead of working on the inflammation in the vascular system, they worked on the oil that was helping it. So that's part of why I don't know.
I'm going to freak you out with my story.
Uh-huh.
I take 120 milligrams of lovastatin a day, which is a lot, and I take 1,600 milligrams of cimetidine or Tagamet a day. So in 2014, when I was diagnosed with stage 4 cancer, Vanderbilt basically said they couldn't do anything to help me, but they would keep me comfortable while I died. So I came across, I call it a God thing, Stephen Cantrell. He's a doctor in Brentwood that went to school at Vanderbilt, and he has different cocktails that he's used with his patients. And for me, he prescribed that. So I take 40 milligrams 3 times a day. And I didn't want to take a statin drug. But his reasoning is behind it. Lovastatin was originally a drug that was being invented. It's the only drug, it's the only statin that works like it works on the market. It was originally a research drug to treat cancer, to get rid of the inflammatory fat that cancer lives
There
in.
you go.
So lovastatin, the other statin drugs do not do that.
Really?
But lovastatin treats, I would not have known this was I not in this circumstance. Lovastatin only treats inflammatory fat, which is where cancer lives. The Tagamet, the 1,600 milligrams of Tagamet a day, he says breaks down the cell wall of the cancer, kind of like when you have a staph infection and you take, an antibiotic.
Mhm.
So I started that. It's just a God thing. Like, I found him. I was not in any position to really make a decision. I was in bad shape. And my sister kind of said, I think you need to do this. And then they started chemo with me. And doctors from all over the world come in to see me because they can't explain me. So we can credit God. We can credit God work through Dr. Cantrell. We can credit whatever. But I'm on that statin drug, just lovastatin. It can't be another statin because it takes away the inflammatory fat. And I will say this, as a cancer patient, you have lots of inflammation. Your pain is from inflammation. Like, large doses of ibuprofen treated me better than an opiate. Like, when I had to have surgery and had to go off my ibuprofens, I was in a lot more pain than when I could take them. So, anyway, it's
Well,
just a strange story.
We really,
Well, you proved Vanderbilt wrong. Good for you.
Well, and he's a Vanderbilt doctor that
Right, but the ones
he
that
doesn't have
said,
privileges anymore. He was a surgeon and a doctor at Johns Hopkins.
where
They
does he,
sent him
what-
home to die. He was a cancer patient.
um,
That's why he began to work with drugs on the market to come up with different cocktails.
so
where does
really,
he work?
we're
He
saying
doesn't.
a little
He has
bit.
an office and he treats cancer patients that other people
Right,
won't.
so- but he has a clinic, or his own.
And his stats are really, really good, but he can't get a clinical trial because he's not using a new drug.
There we go.
So
That's interesting. So really, the dietitian is right.
she's exactly right.
Yes, but there's only one statin that really,
Treats inflammatory fat, and it's the inflammation that lovastatin takes out. I would not have known that had it not happened to me. And when he told me he wanted me, based on my weight, it's all based on weight, that he wanted me to take that much, I was like, I can't take that much lovastatin in a day, I'll die. No, it's like up to 250 milligrams a day is within USDA. And like Tagamet, like you buy it over the counter, you take 20, so when you tell me 1,600, you can take, within USDA guidelines, it's 2,400 milligrams a day.
You could take that much.
and how much lovastatin are you taking?
40 milligrams 3 times a day. I take it, it has to be taken TID. I take it at 6 a.m., 2 p.m., and 10 p.m.
And then Tagamet's doing, saying again, what Tagamet
Tagamet
is?
destroys the cell wall. Thank you. Yeah, and I take that at 8 a.m. and 8 p.m.
How much
and
of that total?
800 milligrams each time, which is 1,600 milligrams total. And I didn't want to interrupt you, but it's like I wouldn't have known that if it hadn't happened to
It's
me.
interesting that statins I've just not felt comfortable about.
Yeah.
And you're kind of reassuring me yeah. Isn't that interesting? Thank
But
you,
he made a
Connie.
big point of Dr. Cantrell. He said it has to be lovastatin.
Mhm.
He said I can't give you another statin drug. It has to be lovastatin because it was invented to treat cancer, but they realized standing alone would not. It had to be mixed with some other cocktails.
Well, and Tagamet will destroy the,
Cell wall.
why do I want that destroyed?
It's like strep, so it doesn't replicate.
Oh,
It keeps it from replicating.
it's keeping it hostile.
Uh-huh.
Really, is what it's doing.
So I have on my chest x-rays, I have calcified spots. And 4 years in, they're shrinking. But, yeah.
That's from the cancer, the calcified spots. Your original cancer was where?
Parotid cyst. Salivary gland.
Isn't that something? Thank you for sharing. That's
But
wonderful.
anyway, it's just
Yeah, and
radio information.
But it's, I've got something more to say about.
But
Yeah.
it's the inflammation that just lovastatin treats. It's the, and you being a cardiac nurse, there's a difference between
Did
fat
you know that,
and
Lori?
inflammatory fat.
Lori, what's because you're a cardiac nurse and
I
statins.
personally don't like statins, but
Why?
They cause a lot of. Sometimes they can take away the cholesterol from your brain that you need.
See?
There's a lot of depression, suicide is increased in a lot of people who take statins. It can cause leg cramps really bad because it just alters.
Did you know
I
that?
didn't know
I
that
drank
about lovastatin,
alcohol.
but that makes sense.
Yes, it does. It
And-
does.
But most of them, like they just give them indiscriminately, like they don't.
Yeah,
Don't
yeah.
stick with the
A
ones
statin
that
is a
really
statin
do.
is a statin.
Because most cardiac disease is inflammatory.
Mhm.
I mean, it is not
Exactly.
cholesterol.
Right.
It's inflammation.
You're
Which
right.
is what Dr. Cantrell said. He said,
Mhm.
you have to treat the inflammation.
Right.
Yeah.
He said it's the inflammation that caused the cancer,
Mhm.
or the cancer causes the inflammation. He said, we're really not sure what
Right.
horse came first, but if you treat the inflammation, then
I
But-
took a few graduate classes in nutrition and stuff, and the cholesterol stuff is just not,
Not the issue.
it's not the issue.
And I think it's interesting for you to say most cardiac problems are inflammation, not big old hunkers of
and for the
cholesterol.
inflammation, my 94-year-old uncle, he is on no medication. He has drank apple cider vinegar every day for 50 years. So I was having leg cramps, and he was at my house one day, and he's like, if you go in the house and drink you like 2 ounces of apple cider vinegar, that'll stop.
Mm.
Well, it did, but I learned you got to dilute that crap.
Oh, yeah.
It makes
I turned that bottle up and thought I died.
And it makes you
But
gag.
within 3 minutes, my legs were not cramping.
Uh-uh.
Within 3 minutes. I mean, like, so.
The body. It doesn't take much
Yeah,
for the body.
anyway,
or
I'm
anything.
sorry. we're
No,
off.
thank you. No, that was good. It was good. All right, let's go back up. Let's see.
Linda has a question.
Huh?
I just wanted to ask one thing. When did statins become so popular?
I want to say
Because,
10 years or more, wouldn't you say?
well, back in the day, we didn't
Uh-uh.
say statin. I like this Metabolic she's talking about. They gave it, but they didn't give it. And they didn't give a lot of these statin drugs.
Uh-huh.
They did it all.
And
No.
now all of a sudden, boom.
That's part of why I said
Uh-huh.
it's a fad. That's why I think that too,
But I
Delinda.
can go along with this Metabolic she's
Uh-huh.
talking about.
Yeah.
I like
The
that.
first
Lipitor.
Lipitor became very popular, and this was weird because I did a little research on this, but the AMA took your blood, cholesterol, and said it needs to be less than 175, 180, and before it had been 200, 225. It coincided with Lipitor when it came out, and a doctor told me, he said, Lipitor is more good at it, and they said it would be better if so the AMA went by what the drug company said about the Lipitor.
I will say this, it did not lower my cholesterol at all.
Sure.
But I didn't have high cholesterol.
Yeah, yeah.
So.
And,
I had
and
cancer.
what are we saying about Lipitor then?
Well, it's just one of those that they gave a lot because the new recommendation came out that your that cholesterol needed to be below 200.
And it's to cut that cholesterol.
Yeah.
But what are you saying? You do like any?
Well, I can't take any of them.
Uh-huh.
I've tried 2 or 3 different
Why?
ones. My
But
legs cramp.
Oh,
Yeah.
cramping.
I
Get
mean,
you
it's
some
just-
apple cider vinegar.
Honey, I haven't drank that, but I used to keep quinine water.
Well,
in the tonic
so
water.
what's the difference in a statin and like Lipitor?
They all come
They,
under statins.
they're all
But
statins.
they
just
are
to-
differences.
Yeah.
It's kind of like blood pressure pills. There's ACE inhibitors,
Yeah,
and beta
yeah,
blockers, and
okay.
diuretics.
I got you.
So it comes that way.
But now, which one is the one that damages your liver?
Huh?
I just remember when I was in our days,
Because I knew
Lipitor was
a
always
lady,
cholesterol.
she was 50.
Yeah, yeah, that's good.
She had high cholesterol and they put her on, I can't remember what they put her on.
Well, the
because she died with
First,
Lipitor.
of course, with chemo, you have weekly labs anyway.
Mhm.
But I wasn't on chemo when he first put me on it, and we did weekly labs. He was watching my kidneys and my liver a lot.
Yeah.
But 4 years in, nothing has changed.
Good.
So, yeah, he actually called me, his nurse called me at home this week and said, we don't have that you've had any blood work done recently, like, when's your next labs? So, I'm like, I've had it done, Vanderbilt's changed their system.
Yeah.
Like, you can't get it.
Yeah.
But I'll get it
That's
to you.
good.
Yeah.
All right, are we at Lepressor? Latrobal. It's really popular for blood pressure, of course. Nitroglycerin, which, of course, dilates the arteries. And then go on down to Inderol. These are all for, and this will dilate again, blood pressure. And
I thought it was, but she's not.
What? What about Inderol?
I was just wondering, it's a beta blocker, right?
Inderol, let me see if
That's how we had, that's how I had to do it in nursing school.
it is a beta blocker.
Okay, that's what I was trying.
Beta blocker. And we're going to talk ACE and betas in just a minute. There's another Pril. So again, we know it's an ACE inhibitor because Prils are APAS inhibitor, which dilate the arteries, resulting in lower blood pressure. And then Ramapril, another Pril. They call them the Pril sisters. Aldactone is a diuretic, which again is helping the blood pressure. And Mavic, I've given it once, I think, but it does the same thing. But it's a Pril. Look at the Pril. And then Verapamil, which is its other name, some people know it by it's Kaline. Let's see, there was something I was going to say about
They
it.
just had a recall on that because it had cyanide in it. Did anybody else
No.
know that?
Just the Kaolin, because I take Metacar, but
The Verapamil, I don't know which one it was, but my mom's on it, and she gets her drugs at Walmart, and they called her and told her not
Oh,
to
really?
take it. It had,
And Verapamil will cut down the
we got that.
rate. Let me go over a beta blocker. We've kind of already talked them, but the beta blocker calms the sympathetic nervous system. And beta blockers a lot of times end in OL. OL. Like Coreg, find Coreg on there, it's an OL. I don't. Tenormin is atenolol, OL. And Inderol's other name has the OL. So beta blockers lower the heart rate and the blood pressure. Beta blockers, ending in OL, so many of them. Low pressure's generic name is an OL, low pressure. And if you are on a beta blocker, you are inclined to have that little irritating cough. If you are in cubicles in an office, you hear them, oh, they must be on a beta blocker. Hear that little cough. Calcium channel blockers lower the irritability and excitability of the heart. And that would be Verapamil is a calcium channel blocker. Lower the irritability and excitability of the heart, which results in a lowered blood pressure and lowered heart rate. I just think, I'm getting ready to tell, Connie tells her war story, I'll tell mine. No, what I think that's helpful, sometimes if you don't get into aunts and uncles and cousins and all, but I guess 6 or 7 years ago I had atrial fib, and I don't like drugs too much. We tried some, but and they were gonna, what did they do? Cardiovert. And I don't think we ever, because I went back in about the time I was on the table to be cardioverted. So finally, he told me, the cardiologist, I said, he was kind of tired of me and irritated because I fight it so, or I really just, I'm not a puppet. And he knew I wasn't, and it was, they don't, you know, it wears them out. Mm-hmm. And so he said, what is it you're wanting? I said, I want off all meds. Mm-hmm. And he said, well, the only way to do it is ablation. And I said, well, let's do it. Well, his partner wouldn't do it, said, unless you were symptomatic and huffing and puffing, just walking across the room, I'm not going to do it. So I told my cardiologist, I said, he won't do it, your partner won't do it. He said, now we can always find somebody to do anything. And that is the truth. He said, so we'll find somebody. If that's what you want, we'll find somebody. So I don't know if he gave me any names. He said, you look around and I'll look around. And so we ended up with two names, Andrew Pickett at St. Thomas, or Heritage, or St. Thomas Middle, and then one at Centennial. And my cardiologist said Centennial. I said, who would you get? And he said, Andrew Pickett, and that wasn't at his hospital. So I went to him. This was about 6 years ago, and he cardioverted. I mean, not cardio, he ablazed. And if you're not familiar with it or are, it's still fascinating to me. And you had to spend one night in the hospital after it was done. Puts incisions in your groin, and as he said, because he described it, it's like a hose, a water hose, garden hose, that he puts up and into the aorta, into the heart, into the atrial. I mean, this is just incredible to me. And at the pulmonary arteries, he said, and I put more freeze to you because he does cryoablation, freezing, not the burning. The burning first came out to burn, but excitability is what made me think of it. He said, so he gets those catheters there, and he blows them up, and then he said, I put more freeze on you than I ever put on anybody, and it blisters and makes a sore. And then he comes back out, sews you up.
In the artery.
Huh?
The heart or the artery?
The arteries. And it has to heal. And I was good for 5 years. This past January, and no medicine, nothing. That's exactly what I wanted. And so, and I get irritated with advertisements on TV when my daddy's so athletic and great, and you see him riding a bicycle, and then she's telling a drug that's so great. And I want to say, why isn't your cardiologist giving your daddy an ablation? So, January, I could tell. I don't have bad symptoms. My worst symptoms, they are hunger. I just have to do that, and I think, wait a minute, I had to hunger air. And I knew I was in atrial fib again. So I called him, went back. He said, my heart fell when I saw your name on the board. And I said, what is your rate of not having to come back? And he said, I ought to be happy with 5. I would like more, but 5's good. And so he did it again. This is the part that's just amazing to me. He went in, he told me what he did. He said, I went in to see what happened. Because apparently, Connie, in doing that, he'd done some freezing spots. He found some hot spots on my heart, too, so he froze. So he doesn't know why it didn't, what's happened. So he said, I went in and looked at your heart. And it's scar tissue is what it is. That sore heals and makes scar tissue so that when the impulses and excitability of the heart they stop at the scars. Is that not just, so the scarring of the heart is what makes that excitability stop. The medicine would do it, but I didn't want that. So he said, I looked at where I'd gone 5 years ago. One place had a little dip. And he said that dip, the excitability was going across. So I knew I needed to burn that again with freeze. Then when he was all over and he came in to talk to me, he said, let me tell you, I took that and went all over the back of your heart. I went all over your heart, and I found one hot spot that had never been touched, and I burned it. Is that not? I mean, you know, and I went to the hospital at 6 in the morning. I was home at 11.
Oh, wow.
Is that a miracle?
Okay, so I'm sorry, I don't know what you're talking about. So it got you off of what type of medicine? Like blood pressure
Atrial
medicine?
fib. The doctor describes atrial fib. It's you're beating too fast.
Okay.
And you just can't. Your heart can't keep that up. And so the cardiologist Pickett said, I attribute it to you're on a bicycle and you're doing fine. You start down a hill, but something made your foot go off the thing. And now it's going so fast I can't get my feet back on the bicycle. Isn't that a good description? Mm-hmm. And he said, you need something to stop that fast to get your feet back on it.
So what medication did that replace? Like, what type of medicine?
Amiodarone was one. I was on that. Anything to slow that heartbeat down.
Okay.
I'm trying to see. I think, the calcium channel blockers.
They don't do much anymore.
I know, but it worked.
What?
I know it did, but
What?
it don't.
Digoxin, Lanoxin.
That used to be a real common.
Yeah.
When they were in the unit and they first went into atrial fib, if we gave it within 70 hours, IV, they went back to the normal.
Digoxin. It's such a great old drug. Yeah.
This for high blood
But-
pressure?
Huh?
Is that for high blood pressure?
Digoxin.
No, no.
Oh, amiodarone.
No, the ablation that you had.
Oh, no, it's really ablation.
Yeah, that's why I was
mostly
asking, 'cause
always.
I'm like, I have to
for,
take medicine for high
what did I say? Atrial fib.
Okay.
Atrial fib, where it's just, you don't have a good, turn in your agenda to that page 8 thing in the agenda. One at 8 where we looked at the lung stuff. Was it page? Yeah. Go to page 8. The bottom, you see the EKG,
Yeah.
the first hump. Atrial fib, you don't have that. You have a lot of humps.
So you're just,
You should, and it's not a good pump into, because see the big V is getting into your ventricles. That's atrium, that first part. And you're just not getting a good pump into there. And so calcium channel blockers try to cut down that excitability. And I'm saying, get an ablation that burns it and makes scar that stops that.
Lydia, I have a question. So what were your other symptoms? I'm curious, besides your tachycardia,
Short of breath.
how fast was your heart rate?
160.
wow.
And then how was your breath? Did you have a hard time?
No, I never had a real hard. It was more. For a while, I would deny it because I lecture, and I try to say so much so fast that I just have to catch it. But it wasn't that I thought, oh, I've got to sit down. And never. It was just like I'd climb step and you have to sit, breathe.
But you're in really good shape.
Yeah.
You really are.
Yeah. So it might be worse for somebody else, but that was really it because I was just so. I'd have to check. Is it really out? And hard to believe it was out.
Well, I've had one as well. So
Do what?
I have had one as well. So that's really
Ablation?
curious, yeah.
Oh, have you? Who did yours?
Somebody over at Vanderbilt
Was it cryo or burn?
burned.
He was the first person 6 years ago that did it in Tennessee, the freezing.
Yeah.
Which is better? He would tell freeze. I've asked him. And have you been fine?
Yeah, I've had nothing since.
And how many years have you?
I was in 2005.
Well, that's a long time.
Oh, now you did better than I did.
She was younger when she
Yeah,
had her first
that's
one.
true.
Yeah.
And are you on medicine?
Yeah, no medicines.
Yeah.
No.
Why do people?
I had the same thing, just increased heart rate. I'd be about 230. It should turn
No.
over like that. I've had my heart stop six times.
Gosh.
Because
But-
people usually go to a medical doctor and they don't know any better themselves and they just get put on a medication.
Yeah.
That's the
I didn't
truth.
want medications anymore, so I'm not.
See, I think that's what, if they get a stubborn patient who gives them havoc, is the only reason. Because otherwise, the pharmaceuticals are doing all the advertisements on TV. And, mine, yours is done 13 years.
I'm not having.
Oh, yeah, your heart's done fine. Oh, thank you for sharing. I mean, this is share day.
I've never
Yeah.
heard of it.
Yeah, it's just the most fascinating.
I've never smoked a day in my life. And I exercise every day.
Oh, well, we probably, oh my, it's 3. Let's break. We hadn't broken. Let's break.